All right. Well, first of all, Professor Hassan, thank you very much for inviting me to join this prestigious panel and to share with colleagues some thoughts about embryo transfer. And number two, it's a hard act to follow up in any session to talk. So, well, I will rise to the expectation and to the fact that I have been one of his fellows, and it has been a great experience. At that, I spent 2.5 years with Bob as clinician and so he always surprises us with ideas, and I still have booklet written after him, and I am only 10% done with the ideas and the question that he wants to ask. So hopefully we will have more time to do more of those interesting ideas in reproductive medicine in general. I'm also happy to join Peter, whom I co-authored a book with him about fertility preservation in cancer patients. So I'll start my talk with this question. If there is a current best way to prepare the endometrium for a frozen embryo transfer. So if we were to answer this question based on the current evidence, the answer would be no. And I would end up at this point, but I think the topic is a little bit more controversial, and also we know very little about that. So if Professor Hassan changed the topic and make it about controlled ovarian stimulation for patients with undergoing IVF, we have a ton of data, and we don't really stimulate any patient like the other. We always micromanage and adjust. So there is a lot of room for individualization when it comes to ovarian stimulation compared to when we prepare the endometrium in a frozen setting. And IVF is moving towards more frozen cycles everywhere all over the world. And that's why it's very critical to understand more about that. So we all agree that we need to have an embryo of good quality of implantation and normal endometrial cavity, but we know the least that we really, excuse me, we need a window of implantation that has to be receptive with endometrial receptivity. And we may have an endometrium that's not receptive, whether that's delayed or advanced. And also the window of implantation itself may not exist at all, or the endometrium can act actively to block implantation in some scenarios. So that is also one of the areas that was never studied or looked at in a methodological way. So to simplify, in order to have a successful outcome, we have to induce endometrial receptivity. There are very simple two ways. Either we exclusively rely on natural sources of hormones to prepare the endometrium, i.e. we need a natural organ inside the body to take that function, which is a corpus luteum, or we have to go hormonal. And on going hormonal, we have to achieve two functions, not only one function. So the one function that we all have is to get the endometrium thicker. That's not enough. We have to completely suppress the corpus luteum internally, because if the corpus luteum is interfering one way or the other in your way of preparing the endometrium, then probably you are not in full control. It's very much like having premature LH rise or progesterone rise, where you are stimulating. If the hypothetically, if the corpus luteum is interfering in the story, it might be confounding the results. So there is no better way to look at what we should do than trying to mimic nature. From this complicated figure, I want you to look into the red, which is estrogen, and the black, which is progesterone. Let's start with estrogen. When we look into the estradiol in the natural cycle, peaks around the LH peak type, and you have a concentration of approximately 400 picogram per ml, and then it drops, and then it rises again in the second half of the cycle, not to the same level. So the concept of dropping the estrogen once progesterone starts is physiologic. So I think we have to think more about that. And with progesterone, you have no progesterone in the first phase, and then it rises to approximately 10 nanogram per ml around the time of the window of implantation. So at the end of your estrogen phase, you have to get the beautiful trilaminar pattern. And within the middle part of the secretory phase, you have to get the homogeneous hyperechogenic pattern. It's not only about the visual look of the endometrium, but it's also about the molecular structure. We're relying exclusively on measurements here, but we don't know what's happening within the structure itself. And again, brings us to Professor Hassan's point about the molecular change that happened in the endometrium. So if this is the same patient, you could see that the endometrium in the second half of the cycle, when you start progesterone, is getting thicker compared to the baseline, which is trilaminar, for instance. So basically, the window of implantation, like Bob said, it begins around day 19 to 20 naturally, and it lasts for up to 4 to 5 days actually. And it switches. If you advance then, or you go in the other direction, that definitely affects the outcome. So from that, we can tell easily that both estrogen and progesterone are needed, but the dynamics between the two are where we have to have better understanding. They seem to be alone sufficient when we have evidence for that from a primate model and from the first pregnancy that was reported after ovarian failure, and what we do with patients without ovarian function by helping them to achieve pregnancy using frozen cycles. So people talk about natural cycle. There are pros for that, which is allowing you to use the endogenous sources. There is no exogenous hormonal support required, and there is a potential cost saving here if money is a problem. The cons for that is you have to have a regular menstrual cycle to consider a natural cycle, and you need additional monitoring visits, and definitely there will be a logistical nightmare for the embryology lab to consider that. Hormonal without GnRH downregulation allows flexible embryo transfer and reduces the amount of monitoring visits. It does not require any endogenous ovarian function. And the cons of that, it would require ovulatory suppressive estrogen support. And here is kind of a cautionary point, because for people who use graduated estrogen, starting with a low dose too, that they last for like maybe 3 or 4 days, if they go longer with a low dose of estrogen, follicular genesis may skip, and they may end up having a corpus luteum in this case. So there's a risk of escape of ovulation if you didn't give a suppressive dose of estrogen. And you have to provide this patient with luteal phase support if you decided to go that route. Very much the GnRH agonist addition to that allow the greatest flexibility, and it eliminates the risk of escape ovulation, but also it is the longest protocol, time and money consuming. So I have few words to talk about the luteal phase support for frozen embryo transfer. So it is considered to be optional for natural cycle if they are unmedicated or if they are triggered with frozen. They are mandatory, so for any medicated cycle. There is a controversy about the right route, timing, dosing, duration. I would like to bring to your attention this article from the Shade Group people when they compared in a randomized fashion the vaginal progesterone, combined vaginal intramuscular and intramuscular alone, and they showed that the vaginal alone is inferior to the other two arms, and that's their interim analysis. We're waiting for the entire trial to be published. Just sharing our experience with that, we went ahead and we changed our protocol for Frozen Embryo Transfer after this article, where we used both vaginal progesterone and intramuscular progesterone every 3rd day. We just looked into our data locally here in Vancouver. I looked into 300 frozen cycles after we adopted this protocol and 300 cycles before, and we found no difference in our experience by adding the intramuscular every 3rd day. So everybody agrees that there is a predominant trend towards blastocyst embryo transfer, but there is no RCTs for the duration of progesterone prior to ET, but mostly we are talking about 6 days before the transfer. The majority of frozen embryo transfers occur within that 6-day window. If you're using blastocyst, mostly it's day 6. And if you're using LH for a natural cycle, it's day 7 from the LH. Numerous dosing regimens The typical duration for luteal phase support after frozen embryo transfer is a minimum of 10 weeks. And I say that because of this classic paper. Sorry?
لو في اسئله بكتبها على questions and answers. ده اسهل. بص على الكويشن.
Sorry. So this is a classic paper that I want you to be aware of. It was published almost 50 years ago in the American Journal of Obstetrics and Gynecology. And when the corpus luteum was removed in 7 pregnant women around 7 weeks of pregnancy, you got both significant drop of progesterone and abortion. But if it was removed a little later, around 61 days, which equivalent to 9 weeks, there's a transient drop of progesterone, but the pregnancy continues. And that's where the 10-week timing is coming from. All the adjuvant medications for frozen are didn't add any value, including Viagra, HCG, steroids, and GSCSF. The markers of endometrial receptivity, the entire spectrum, whether ultrasound, histological, biochemical, or molecular or gene microarrays, needs further validation. And Bob already talked about the compaction. And by compaction, he means a change. So the patient is used as our own baseline and then a change to happen later. And Professor Hassan already mentioned this article about the endometrial thickness. It's 8 millimeter for fresh and 7 millimeter for frozen. The ERA, or the endometrial receptivity assay, I'm sure all of you heard about it, but I think it is yet to be validated in order to be used routinely in clinical practice. And again, we have some data that came out of our center that we didn't see a huge difference. So for the estrogen primer summary, you can use oral, which is what we use. We switched to transdermal for patients with persistently thin endometrium. It's more expensive. We use oral and vaginal for those as well. Duration, actually, that's Professor Hassan's point. There is data, there is basic science data that 7 days is enough. So the minimum you could go is 1 week, but you can go up to 5 weeks, even up to 2 months in some scenarios. The key is to achieve the normal pattern, which is a trilaminar endometrium. As far as the dose of progesterone, there is also studies that looked at the physiologic level where they showed that if you have a circulating level of progesterone more than 5 nanogram, that would be enough to drive normal endometrial, normal luteal progression. And you can achieve that with the minimum dose of 50 milligrams intramuscular per day, or vaginal at least 50 milligrams BID per day. But on the other side, there's no disadvantage to the higher doses. That's why there's a wide dose variation in using progesterone. I think I would like to bring to your attention the safety point, and that's the last slide or the last couple slides. So there is data about the fact that for medicated cycles, we have an increased risk of hypertensive disorder of pregnancy. And this is a huge study that was published in Human Reproduction. And there is increased incidence of placenta accreta spectrum, but there is decreased gestational diabetes mellitus. There is another study in hypertension that showed that IVF without a corpus luteum was associated with impaired maternal circulatory adaptation to pregnancy and consequently increased risk of preeclampsia compared to natural cycle. So research-wise, what do we need to do? There are lots, but pre-treatments, different subgroups of patients, endometriosis, adenomyosis, C-section scar niche. I have some experience with treating them with GnRH analogs now, and some of them actually conceive naturally even before taking them to embryo transfer. We're putting together this experience and we'll publish it hopefully soon. There are no RCTs on the duration of progesterone treatment prior to FT, but there's a consensus about a minimum of 6 days in the context of blastocyst transfer. Endometrial compaction is a new area for research, and we have the two extremes here. The one piece of data from Dr. Kasper's place versus Chinese. We have to put some emphasis on safety and look into what happens with medicated cycles. And probably it's time to look into individualizing the protocols for patients with frozen embryo transfer the way we individualize protocols for ovulation induction. And that's all I have to say. Thank you.